The following educational video was created in collaboration with the Faculty of Biomedical Engineering of the Czech Technical University in Prague and the first surgical clinic of the General University Hospital. A stoma, or an artificial opening, is the surgical exteriorization of a hollow organ onto the surface of the body. Most commonly, it involves bringing out the large or small intestine or urinary tract onto the abdominal wall. Stomas created from the large intestine are collectively referred to as colostomies. Colostomy is the most common type of stoma. The externalized large intestine typically measures between 2 and 5 centimeters in diameter and protrudes 1 to 2 centimeters above the abdominal surface. Colostomy expels solid waste resembling stool and is usually emptied once or twice a day depending on diet. Classification of colostomies by location. Ascending colon, ascendostomy. Transverse colon, transversostomy, which typically expels semi-solid content. Descending colon, descendostomy. Sigmoid colon, sigmoidostomy, which produces firm, formed waste. Ostomy on the small intestine, jejunostomy, most often indicated for administering medication and nutrition directly to the small intestinal mucosa. Ileostomy, an opening from the small intestine. The higher up the stoma is located on the intestine, the more liquid and aggressive the intestinal waste will be, as it continuously flows from the stoma. Proper care of the stoma's surrounding skin is crucial to protect it from irritation. The externalized small intestine protrudes more above the abdominal wall to prevent the highly liquid and aggressive contents from damaging the peristomal skin. Classification of stomas by duration. Permanent, created when there is no possibility of restoring the function of the organ. Temporary, performed to relieve the lower segment of the intestine, and can be reversed after the problem is resolved. However, if the patient declines further surgery or complications arise, a temporary stoma may become permanent. Classification by construction: loop stoma, axial, terminal, double barrel. Axial stomas, created by exteriorizing a loop of the small or large intestine. The loop may be supported by a plastic rod and has both an afferent and efferent limb. This stoma can be temporary as a protective measure for a distally created anastomosis in the gastrointestinal tract, with the goal of early surgical closure. Alternatively, it can be permanent in palliative procedures for otherwise inoperable conditions. Terminal stomas are formed after resection of the rectum or in cases of severe inflammation, with the remaining bowel brought to the surface as a terminal stoma. If healing is successful, the bowel ends can be reconnected and the stoma closed. Double-barrel stomas, typically created in cases of intestinal obstruction requiring bowel resection. Both externalized ends allow for visual inspection of their viability. Replacement of appliances in uncomplicated stoma. The type of stoma appliance is recommended by a specialized stoma nurse. Based on the type of stoma, the patient's physical build, abdominal contours, associated conditions, and manual dexterity in managing the stoma. Patients should be evaluated in sitting, lying, and standing positions to determine the best fitting appliance. Terminal ileostomy care. Stoma care does not require a sterile technique but involves specialized equipment. The removal of the existing appliance should be done using an adhesive remover to facilitate gentle detachment. A cleansing wipe or stoma foam is used to clean the stoma and its surrounding area. If necessary, the passage through the stoma can be checked using a moistened fingertip, performed by a trained stoma nurse or a doctor. The continuous outflow of aggressive intestinal contents can complicate the appliance change. And in cases of narrow stomas, a small tampon may be temporarily inserted by trained personnel. The use of protective powder is important early after surgery for suture care, aiding in the healing of the stoma. It can also be applied to minor injuries under the appliance. However, excess powder should be brushed off, so that it remains only in the places where it is needed. Protective film. It acts as a skin barrier and increases the adhesion of the appliance, which we apply only after it has completely dried. We treat the entire peristomal skin with it and can also apply it to the stoma mucosa. In the selected appliance, we measure and cut an appropriately sized opening. By placing the appliance, we verify the size of the cut opening, which we can further adjust if necessary. The sealing ring adheres on both sides. It serves as a seal and compensates for any irregularities around the stoma to prevent leakage of waste under the appliance. The ring can be freely shaped and adjusted to fit the stoma. We place it and gently press it to ensure proper adhesion to the skin. After removing the protective film from the base plate, we apply adhesive paste around the cut opening and let it set for approximately 10 seconds. The paste fills minor irregularities around the stoma, preventing leakage of contents under the appliance, thereby helping to maintain healthy peristomal skin. The adhesive surface should not be touched. After applying the base plate, it is advisable to gently press the appliance around the stoma with a moistened finger to ensure good adhesion to the skin. This is especially important for ileostomies, where the waste is aggressive. The peristomal skin must be completely covered with only the stoma visible. We snap the pouch onto the base plate with a guiding ring, and if a tampon is in place, we carefully remove it. We check that the pouch is securely attached and that the outlet is closed. Drainable pouches may have a Velcro closure at the bottom, allowing waste to be emptied without removing the pouch. Terminal colostomy. Colostomy care is easier. The stoma discharges solid stool and is emptied approximately once or twice a day, depending on diet. The surface of every stoma is always moist and shiny. Since there are no nerve endings in the mucosa, it is not sensitive to pain. After treating the peristomal skin, we measure and cut a convex base plate, testing the opening size before application. For this type of appliance, the opening should be cut 3 to 4 mm larger to prevent damage to the stoma. Solid stool passing through the colostomy increases the volume of the intestine, which could lead to stoma constriction. Double barrel stoma. If anatomical conditions allow, it is constructed so that the afferent loop carrying stool is sutured higher above the abdominal wall to avoid complications in stoma care. For appliance removal, we use adhesive removers and clean the area around the stoma with stoma care foam. Special care is taken when wiping near the intestinal mucosa to prevent bleeding. The care and use of accessories for this type of stoma are the same.